Thank you so much. And I'm absolutely delighted to be here. It's an incredible privilege to be able to talk to this audience. I guess maybe in the interest of brevity, I'll say that I think I probably have three messages that I'm going to try to deliver here. The first actually is, I guess, to build on the last comment, is that I would like to take a moment to recognize that there's been enormous progress in this actually over the last 20 years, and that we're all here to try to move that progress forward. But I realized as I came here today that it's 20 years since my K Award was funded on access to genomics, access to BRCA testing. And at that time, I can tell you, there was no chance there was going to be a meeting like this. There was nobody interested in talking about it. Nobody wanted to talk about access for vulnerable populations to genomics. So I just want to congratulate the roundtable on where they are and where we've come. That doesn't mean we've got a long way to go, but just want to take a moment to say that it is fantastic to see that. I'm here now not as a researcher, but because I lead a large clinical department with 1,100 faculty, and I spend a lot of time on the healthcare delivery side as well as on the payer side, as we have that also. And I guess the two messages that I want to give about, at least from that seat, where I think we have major opportunities, are first, that we have come so far in genomics now that we have genomic tests or genomic strategies that should be moved out of the genomics community and into the quality improvement and delivery world. And what that means is that there are apparatuses at all of our institutions that are responsible for making sure that people get antibiotics in timely manners when they show up with sepsis, and that they get cancer screening when they're supposed to, and that there are tests and strategies right now that we need to hold accountable at the quality improvement level in our systems. And that is particularly true for disparities. And I'm going to give you an example of that. And then the second piece I would say is that for tests and strategies where we're not there yet, we need to find a way to develop those processes and to develop the evidence and the belief, I will say, that we've created a process that works and that we can then move that into the healthcare system and hold us accountable for how we're going to do that. So I'm just going to talk a little bit first, just for a second, to talk about some of the background in cancer, because I think as we've heard across the day, cancer probably fits that first category, as I was suggesting. There are tests and strategies where it is not acceptable that we are not delivering them to patients equitably across our communities. We have worked on this for some time in genetic testing for breast cancer susceptibility. This is a study that we published a while ago that actually showed in the communities where we were studying it in Pennsylvania and across some other states, we looked and tried to ask the question, why were Black women with breast cancer much, much less likely to get BRCA testing at the time of diagnosis? What we found in these populations was that it was not actually because they were going to the different doctors, which I have to say every R01 I write, the hypothesis I come up with is always wrong. So I have to say most of my advice to my mentees is put down the opposite of what I suggest as your hypothesis. I thought they would be going to different doctors, and that's why they would get different rates of testing. It turns out that doctors had different rates of recommendations based upon the race of the women they saw. And so that happened, I think, partly because of the lack of evidence in the doctors' minds about the utility of testing in that group. So when we know something works, we need to figure out how to get the healthcare system to actually start delivering that equitably across groups. So this just shows that when we took that population of about 3,000 women with breast cancer, we adjusted for mutation risk. There was still a significant disparity between Black and white women. We added in clinical and sociodemographic factors. That disparity got a lot smaller. When we go to the physician, so again, the thing I thought was going to explain it, they were going to different doctors, huge segregation in our country between who takes care of different groups in our country, huge segregation. Turns out it was highly segregated, but it did not explain the difference in the actual use of testing. What explained the difference in the use of testing was who had recommended what to which patient. So I would say that first, I just want to be clear, as we think about moving forward, we need to make sure that we have tools that are effective in different groups. And that's not what this conference is about today, but I couldn't be more enthusiastic about the genomics community's commitment to increasing the diversity of individuals in genomics research, to developing tools that actually reflect the populations who we serve, and making sure, and I was going to show a little bit of data about this because I think she's here in the audience. Here's a study from Latrice Landry that shows that we have trouble with the tools right now. These are actually data about cardiomyopathy and our ability to detect actual positive tests varies by the race or ethnicity, ancestry, obviously, of the patient who we're serving. And particularly, I think is frustrating for those of us who spend time clinically in the area is the inconclusive parts. So we need to continue that, but that's not the focus today. What I will say is that when we have got a tool that works, a disparity in the delivery of that tool is a quality problem. Equity, we're standing here, and now the National Academy of Medicine, the IOM quality would tell you that equity is a quality metric and we need to hold ourselves to equity. And so I would say that moves it out of the kind of where we're thinking about it on one, development of the test and does it work, into the quality infrastructure of an institution. That usually includes provider and patient education, development of decision support, measurement and feedback, and I will tell you, targeted process improvement projects we do all the time. Like, why on earth is it that nobody noticed people wait 2 hours in the pulmonary clinic, right? Like, when you figure that out, you've got to go in and fix it. I will tell you, we at MGH, and I had nothing to do with this, let me just make it very clear, absolutely nothing, are incredibly lucky to have an organizational unit that leads this. It's called the Disparities Solution Center, and I encourage you guys to look at it. They hold me as the chief of medicine accountable for reporting out rates of what we are supposed to do for our patients by all sorts of things, not just race and ethnicity, English proficiency, location, insurance status. You can get it on the web. I don't know whether we have one from the last year, but I can tell you I see it every year. And when we find a disparity in colorectal cancer screening or whatever, it's my problem to fix it. And we fix it. I'll say there's another piece, so let's just put cancer aside for a second. I think in other areas, we desperately still need to build the tools that work. Figure out how are we going to deliver genomic medicine outside of cancer. And so I'm just going to tell you the story of what we're trying to do now. So we were lucky to recruit Heidi Rem, who many of you guys probably know, has been working on this a lot, to come over and work with us as what we're calling the Chief Genomics Officer. I'm not really sure what that means, but it sounds good. And we're working on two key issues: availability, who's going to order the test and manage the results, and affordability, who's going to cover the cost of the test and how are we going to deal with that. Acceptability is critical, but I'm not going to spend time on that here. We're also fundamentally trying to hold ourselves to that standard, that even as we develop this, how do we make sure that we're not creating disparities in this effort? So we're thinking about and have started on this and working in our genomics service, as you've heard from many others, across 3 different categories of tests. The biggest demand I have is actually panel testing that's used in our specialty clinics. We've identified a genomic lead physician for each of our specialty clinics who has agreed and will serve as the primary source for that specialty to manage this information to ensure it's happening. The patients in these worlds are largely symptomatic, as you all know. We're working hard, and this is not easy, on the population health strategy for predictive genetic testing. Many people have done this. It's a heavy lift for the primary care practices, but it's something that they're increasingly committed to, and we need to do that. And I'll come back to this, hold our population health folks accountable for the ones that we know need to happen. And then we, as many others, have developed a specialized service to do whole exome testing for patients in multidisciplinary settings, often are referred to us because they have unexplained presentations. So this is the approach that we're using right now, which is really 3 pillars. Who do we train to order the test? who counsels the patients around these testing, who does the test. Turns out when we started this, like providers were sending tests to all sorts of different labs all over wherever. There was no sense of equality and kind of which labs we trust, which labs we need to repeat the test if you get it done in that lab. We've tried to bring that all in, so we have a list of labs, internal, external labs, that we believe we can use. Who interprets it has become a big issue, and with Heidi's leadership, we've now created a genomics service with clinical genomics individuals who are hired really to work with the physician and go through the data that they don't necessarily understand. Obviously, a lot of investment in the reporting that's already been done that I won't go into. There are huge equity concerns here that keep me up at night. It is incredibly hard to hire people who speak Spanish. I work crazy, crazy hard on it. Sometimes I think the best option would be that I just gave somebody else my job and I learned to speak Spanish. I'm quite sure that there are many more people who could do my job well than trying to find this. It's just such a critical issue for us, let alone other languages. The number of languages spoken in the populations who I serve is 32. 32 languages. It's really incredible. Continuity. For people who have limited resources, the ability to get to visits, to come back, they get moved around constantly, is incredibly hard. Provider resources, perceptions of clinical utility, as I got back to, doctors just don't seem to think this applies. It's a huge issue for us. And then actual clinical utility. So we have worked on developing a genomics service. I won't go through what they do. You've heard this before. And now I'm really focused on trying to get to the bottom of this. How do we take that clinical effort and actually engage it in our communities and try to ensure that we're not creating disparities as we try to build this first effort? I'll just say 2 seconds about the financial piece. If you all have not seen this PACE by Jochen Lennertz in the Journal of Molecular Diagnostics, it is a complete eye-opener. So essentially did a map of what it takes to get these things actually paid for, a heat map here. The rows are insurance providers, the columns are different billing codes, and it's chaos. It's like complete chaos, what is going on. This is just in Boston, just in our service, trying to get this done. It turns out this is the form. It's incredibly, this is the form for BRCA testing. Have you guys ever tried to do this? I mean, I'm a primary care provider. It's like, anyway, I don't have to say it. I'll just keep that to myself. This is actually from Jochen's paper. It's amazing. This is what they created on the left to create a system to actually get it paid for, to actually get, and these were commercial insurance. This was in commercial insurance. I'm going to come back to that in just a second. If you look at it at the end of it, I'll just point out that one number. It was 114 days. One of the biggest problems was that by the time you get to doing the test, your actual insurance approval has run out because it only lasts for 90 days. So you've got to go get it all again. I'm not going to read this, but this is a short number of emails that involve me. You can see at the top says, "Hi, KATRINA. To make things a little easier, here to follow is a brief summary." This is one Medicaid patient that we had on our service that we tried to get an exome paid for. An incredibly important case that we ended up finding a major new mutation in this individual, has major implications for his bone marrow transplant I won't go into. But it took immense numbers of emails to get this done. And I thought it was amusing because you can tell that over time, and this is multiple emails, it goes from black to red. Usually I can tell in my own email inbox, like if it starts going from black to caps to red, like it's not good. And so it's one of the signs as a chair of medicine that like you should probably read those emails more. One of the issues that I would strongly encourage us to pay attention to is that in our country, disparities and source of insurance are incredibly strongly correlated. An enormous number of the patients who we're talking about here are going to be covered by Medicaid. Medicaid in our country is moving to a managed care product. If you look at the map here, you can see that. If you look across any of your states, I'm sure you see that. We just moved to this fully in the state, or in the Commonwealth of Massachusetts. We need to have genomics at the table to be discussing how that is going to work within Medicaid managed care. It is just that one patient I showed you moved Medicaid plans 3 times from the time when we started trying to get his exome covered until the time that he actually got his exome covered. It's an incredible amount of issues, but it's a huge opportunity. If the academic and genomics community stands up and makes an argument right now of why this should be critical to not exclude the Medicaid populations from this revolution in medicine, we have an unbelievable opportunity. So I'm just going to end by saying that my life, in many ways, is based upon budgets. So we're in the middle of budgeting season right now. I don't know how many of the rest of you guys are. But what that means is that we make trade-offs, just like you heard earlier. And what I usually am making trade-offs is between the stuff on the left, which we call our supply budget, the people in the middle, the hospital costs, which I think is more sometimes on the payer side, but is real, and the drugs and pharmaceuticals. At the Mass General this year, our supply budget, which includes pharmaceuticals that are given through IVs, right, so infusions, went up 34% from last year. So it is an extraordinary time for the rising cost of devices, supplies, and pharmaceuticals in our society. The National Academy of Medicine just wrote a report called Making Medicines Affordable. And I would strongly encourage you all to read that report and write your, maybe I'm not allowed to say this, write your congressman. It's an incredible report. And for us to be able to do the things at the bottom here, to take precision medicine where it really can go, we are going to have to stand up about these other things. So thank you so much. I'm delighted to answer questions.